Hello, welcome to Session 4 of the CE program, Navigating Pain Management, Safe Opioid Prescribing, and Opioid Use Disorder, brought to you by Southern Illinois University, Edwardsville, and the Illinois Prescription Drug Monitoring Program. Today, we will be focusing on opioid analgesics. My name is Camille Dunkley. I am an assistant professor of family and community medicine with Southern Illinois University School of Medicine, located in Springfield, Illinois. I have no financial disclosures to declare. The two main learning objectives are to review opioid pharmacology and review clinical and adverse effects of opioids. Let's begin. Opioid receptors are 7 transmembrane G protein-coupled inhibitor receptors. There are 4 types: the mu, kappa, delta, and nociceptin receptor. The first 3, mu, kappa, and delta, are considered to be classical opioid receptors. The last receptor, nociceptin, is structurally similar to the classical receptors but has a different pharmacology. The mu receptor is primarily responsible for the pain-relieving actions and also the adverse effects. Opioid signaling. In the presence of an opioid agonist, the opioid receptor becomes activated. This leads to activation of several G protein subunits, which provides a complex pattern of downstream intracellular signaling. This signaling pathway is the same for all types of opioid receptors. Opioid receptor function. Mu receptors are found in brain regions that control the sensory component of pain and behavior modulation. For example, the amygdala, the ventral tegmental area, the thalamus, and the hippocampus. The mu-2 receptor is associated with respiratory depression. The kappa receptor has a role in diuresis, pain perception, stress, and food intake, and are located in the caudate putamen, the pituitary, the hypothalamus, the raphe nuclei, and the pons and the medulla. The delta opioid receptors are involved in modulation of pain and mood, and those receptors are located in the caudate putamen, the nucleus accumbens, and the amygdala. The nociceptin receptors are the most widely distributed receptor, and they are found in the brain and the spinal cord, and they modulate pain, reward, anxiety, and stress. There are several routes of opioid administration. In addition to the more common routes of administration, like oral or parenteral, others have been developed to improve the efficacy of the opioids while decreasing side effects. For example, spinal or neuroaxial administration. This type provides direct access to pain synapses in the spinal cord. Epidural administration of opioids is popular for post-operative pain management and during labor and delivery. This route causes less respiratory depression due to decreased systemic levels. Transdermal administration are approved for use in sustained pain because its longer duration of action, stable therapeutic blood levels, and its ease of use. The classic example of this are fentanyl patches. Rectal administration is usually utilized for patients with oral pathology or patients having difficulty swallowing and are not interested in parenteral administration. However, this route is not tolerated well by pediatric populations. The principal indication for opioids are pain management. According to the CDC Clinical Practice Guidelines published in 2022, in acute circumstances, opioids are indicated for moderate to severe pain not responsive to non-opioid medications, and the prescription should preferably be limited to 3 days. For chronic pain, it is indicated for pain severe enough to require long-term opioid analgesia when alternative therapies have been deemed inadequate. In these instances, it is still recommended to begin with immediate release formulations. Extended release formulations are reserved for opioid-tolerant persons who require around-the-clock opioid analgesia. We are now going to review the 3 most common therapeutic effects of opioids. Analgesia. Opioids control cerebral cortical pain perception at the supraspinal, spinal, and peripheral levels. The highest concentration of opioid receptors are found in areas of the brain associated with analgesia, such as the periaqueductal gray, the nucleus raphe magnus, the locus ceruleus, and the medial thalamus. Antitussive. Cough suppression occurs through several mechanisms: agonism of the mu2 receptor, agonism of the kappa receptors, and antagonism of the delta receptors. Codeine and dextromethorphan are two opioids with cough suppressant activity. Euphoria. The pleasurable effects for most substances are facilitated by dopamine release in the mesolimbic system. Opioids activate the mu and delta receptor complex in the ventral tegmental area. This indirectly leads to dopamine release in the mesolimbic region. We are now going to discuss adverse and toxic effects of opioids. There are several labeled warnings and precautions associated with opioids. The list on this slide is not exhaustive, but includes risk of life-threatening respiratory depression, gastrointestinal effects, adrenal insufficiency, risk for addiction, abuse, and misuse, hypotension, neonatal opioid withdrawal syndrome, and precautions when using in head injury or increased intracranial pressure with CYP450-mediated drug interactions, when driving and operating machinery, and precautions with concomitant use of benzodiazepines or other CNS depressants, including alcohol. Respiratory depression. The mu receptor is constantly implicated in the respiratory depressant effects of opioids. Opioid agonists decrease ventilation by weakening the sensitivity of the medullary chemoreceptors to hypercapnia and hypoxia. This results in a loss of stimulus to breathe. Equianalgesic doses of opioid agonists yield the same degree of respiratory depression. Opioid agonists, antagonists, and partial agonists demonstrate a ceiling effect on the respiratory depression. Respiratory depression is the primary cause of death after therapeutic use or misuse. Cardiovascular. Opioid-induced hypotension is mediated by histamine release. However, this release does not appear to occur through direct interaction with the opioid receptor. It is thought that it might be related to a nonspecific ability of a certain xenobiotic's potential to activate mast cell G proteins, which induces degranulation of histamine-containing vesicles. One study observing the effect 4 different opioids had on 60 healthy individuals found that meperidine produced the most hypotension and elevated serum histamine concentrations, while fentanyl produced the least. Seizures. At therapeutic doses, seizures are a rare complication for most opioids. At toxic doses, seizures are commonly associated with meperidine, tramadol, and propoxyphene. In an opioid overdose, seizures are most likely related to hypoxia rather than the opioid itself. Movement disorders. Intravenous administration of high-potency opioids like fentanyl may lead to acute muscular rigidity. The exact mechanism is unclear, but it may be related to dopamine blockade, GABA antagonism, and NMDA agonism. It has been suggested that this muscle rigidity may contribute to the lethality associated with fentanyl overdoses. Constipation. 40 to 80% of those taking opioids are estimated to experience constipation. Opioids inhibit the myenteric plexus, resulting in decreased peristalsis and bowel tone, increased water absorption from intestinal lumen, and increased anal sphincter tone. Laxatives are considered to be the first-line therapy, followed by peripherally acting opioid antagonists as the second line. There are no recommendations for chloride modulators or serotonin agonists. Hypogonadism. Chronic opioids are associated with hypofunction of the hypothalamic pituitary gonadal axis. It is caused by opioids binding to the hypothalamic opioid receptor and decreasing the secretion of gonadotropin-releasing hormone. Clinically, findings include decreased libido, depression, anemia, hair loss, erectile dysfunction, and hot flashes, and it may affect fertility of both men and women. It occurs in approximately 35 to 90% of those on chronic opioids. Hyperalgesia is characterized by an enhanced response to a noxious stimulus or pain. Opioid-induced hyperalgesia is a paradoxical, unexpected response where a patient might become more sensitive to pain following opioid therapy. This is different from opioid tolerance. The table below shows some of the differences between opioid tolerance and opioid hyperalgesia. In general, opioid hyperalgesia, the nature of the pain becomes more diffuse compared to baseline and can extend to various locations amidst increased sensitivity. Also, it is not dependent on the duration of exposure or the dose escalation. Studies have found that chronic opioid use can increase the risk of having a new depression episode. The exact underlying mechanism is not known, and it's unclear if the characteristics of the depression is different or similar to depressive episodes not associated with chronic opioid use. Hearing loss. Rapidly progressive sensory neural hearing loss may occur in heavy opioid use. It is most associated with hydrocodone, oxycodone, and methadone. The exact mechanism is not known, but some suggested causes include ischemia, direct cochlear toxicity, genetic predisposition, and a hypersensitization that occurs with re-exposure following an opioid abstinence. Most patients who experience this have a full hearing recovery after an opioid abstinence. However, some may require cochlear implants. Opioid use in special populations. Pregnancy and lactation. Weigh the benefits and the risks with focus on maternal factors and drug-related factors. For example, stage of pregnancy during exposure, route of administration, and dose. Use of contraceptives should be discussed when opioid therapy is required for females of childbearing age. In pediatric populations, avoiding codeine and tramadol is important. In older adults, using lower doses and extended dosing intervals is recommended. For patients or individuals that have respiratory disease, consider use of a mixed partial agonist like buprenorphine. For individuals with hepatic dysfunction, avoid codeine and meperidine and use lower doses and extended dosing intervals. For renal dysfunction, avoid codeine, meperidine, and morphine, and again use lower doses and consider extended dosing intervals. For patients or individuals with opioid use disorder, in situations of acute pain, ensure appropriate access to opioids and indicated with close monitoring. In instances of chronic pain, consider use of buprenorphine or methadone, but remember that buprenorphine and methadone must be dosed more frequently than once a day for effective analgesia. We are now going to discuss individual opioids in more detail. Here is a list of mu agonist opioids arranged by potency, with fentanyl at the top having the highest potency and meperidine at the bottom having the lowest potency. Meperidine. Today, meperidine is rarely used for analgesia, even though once it was considered the opioid of choice for pancreatitis. Today, it is still used for post-anesthesia shivering in combination with antihistamines, corticosteroids, acetaminophen, or NSAIDs. It has a shorter duration of action compared to morphine, and there's an increased risk for CNS excitation, including tremors and muscle twitching, because of the accumulation of the neurotoxic metabolite normoparity. This risk seems to be higher in persons with renal dysfunction. Codeine is a naturally occurring opiate and a prodrug. While the parent drug retains the antitussive effects, analgesic effects require metabolic activation to morphine by CYP2D6 enzyme. There are many polymorphisms associated with this enzyme, resulting in poor activity, intermediate activity, or ultra-rapid function or activity. For those individuals with ultra-rapid CYP2D6 activity, large amounts of morphine are expected after ingesting codeine, which can lead to opioid toxicity. Tramadol is a weak mu receptor agonist and a serotonin and norepinephrine reuptake inhibitor. It is also a prodrug and is extensively metabolized by CYP2D6 and CYP3A4 enzymes. Its two metabolites are more potent than the parent compound and contribute to the analgesic effect. It is used to treat mild to moderate pain and is associated with risk of serotonin syndrome, risk of seizures, also a higher fall risk compared to other opioids in older patients, and it is associated with hypoglycemia. Tapentadol is structurally similar to tramadol. It is also a weak mu receptor agonist and a norepinephrine and serotonin reuptake inhibitor, but has significantly more potent effect at the mu receptor. It is also FDA approved for diabetic painful neuropathy. Morphine. Morphine has a poor bioavailability, with only 25% being available after oral administration. The major pathway for metabolism is conjugation with glucuronide acid to produce morphine 3-glucuronide and morphine 6-glucuronide. Both of these metabolites can pass the blood-brain barrier. Morphine 6-glucuronide has similar pharmacological actions as morphine, but is considered twice as potent. Oliceridine is the first ligand-biased mu receptor agonist. It also theoretically spares beta-arrestin pathways, which leads to less respiratory effects. It is indicated for severe acute pain and should not be given longer than 48 hours, and it is available parenterally only. Methadone is a long-acting mu receptor agonist, a serotonin and norepinephrine reuptake inhibitor, a sodium channel antagonist, and an NMDA glutamate receptor antagonist. It is absorbed well through the GI tract with the onset effect 30 to 60 minutes following oral route. It has a long and unpredictable half-life varying from 15 to 60 hours. It also has a variable equianalgesic dosing. There are several drug-to-drug interactions mediated through the CYP3A4 enzyme, CYP2C19 enzyme, CYP2D6 enzyme, and CYP2B6 enzyme. It is unique in that it is associated with QTC prolongation, and this effect is also additive when used with other substances that cause QTC prolongation. Therefore, routine ECG monitoring is recommended. Fentanyl. Fentanyl is a short-acting opioid. It has a high lipid solubility and rapidly crosses the blood-brain barrier. It is considered to be 50 to 100 times more potent than morphine. The binding affinity for the mu receptor is similar to both morphine and naloxone. The naloxone dose required to reverse a respiratory depression is similar to other common opioids. However, when large quantities of fentanyl are involved, then higher than normal doses of naloxone may be needed. There are several mixed agonist-antagonist opioids. These substances have clinically useful analgesic effects but less respiratory depression. Buprenorphine is a lipophilic partial mu receptor agonist that is 50 times as potent as morphine but less efficacious. Its primary therapeutic use is management of opioid use disorder, where it controls opioid cravings and serves to block the action of higher efficacious opioids. It is also a kappa antagonist and a partial agonist at the nociceptin receptor. Pentazocine, nalbuphine, and butorphanol have similar mechanism of actions, where they are all kappa receptor agonists and partial mu receptor agonists. Pentazocine was created to develop an analgesic with a minimal abuse potential. It is indicated for mild to moderate pain. As mentioned, nalbuphine is very similar to pentazocine, but has fewer side effects. Butorphanol is used for acute pain relief, for example, post-operative pain. However, it has cardiovascular side effects and so should not be used for patients with congestive heart failure or myocardial infarction. Opioid antagonists. Opioid antagonists are substances that bind competitively to one or more opioid receptor. They display little or no intrinsic activity and antagonize the effects of respiratory agonists. Naloxone and naltrexone are devoid of agonist activity and interact with the mu, delta, and kappa opioid receptor. They do not appear to bind to the nociceptin receptor. Naloxone is established as treatment for opioid-induced toxicity, in particular the respiratory depression. It acts rapidly and the duration of action is short. Naloxone and naltrexone primarily works centrally. Methylnaltrexone, however, has a poor bioavailability and works peripherally. Opioid antagonists are used in treatments of opioid overdose, opioid-induced constipation, and alcohol use disorder. A summary of key prescribing principles include: attempts should be made to keep initial or acute opioid prescriptions to a short duration as possible. Patients should be reevaluated at 30 days or less. Using the lowest effective dose is important because any dose increase can increase the risk. Providers should avoid utilizing long-acting or extended-release formulation opioids in opioid-naive persons. Methadone or transdermal fentanyl should be avoided when possible. Assessing the improvement in pain and function, as well as adverse effects, should occur at each appointment. Complete risk mitigation strategies, provide medication and overdose education, for example, offering naloxone during each interaction. Thank you for listening.